Good afternoon, everyone. On behalf of the panelists, thank you for joining us. And pleasure mine to be the moderator for today's session. This webinar is specially organized by the National University of Singapore, Yong Loo Lin School of Medicine, NUS Nursing, to promote awareness and interest among healthcare providers and researchers to create new knowledge towards the care of older adults with dementia. Before I start the ball rolling, I will now invite Professor Emily, the Head of Department for NUS Nursing, for the welcome speech.
A very warm welcome to our webinar. Thank you for your support. I'd like to introduce briefly our department to all the participants. Our department is known as the Alice Lee Center for Nursing Studies. It is within the Yong Loo Lin School of Medicine, National University of Singapore. NUS is Singapore's flagship university and a leading global university centered in Asia. We offer undergrad and postgrad programs and have a total population of over 1,000 students. Our research program covers the following: chronic illness and long-term care, women and child health care, patient safety and quality of care, geriatric care, and wellness. I hope that you can go to our website to learn more about our department and our research program, and we welcome all of you to collaborate with us in the future. Let me once again thank you for participating in this webinar, and I hope you have an enlightening one today.
Welcome once again. I'm Roslyn, a faculty member of NUS Nursing. And together with me are three distinguished speakers who will share on their research projects for today's theme: Impact of Age on Cognition among Community-Dwelling Older Adults, Dementia Awareness. I believe everyone here today would resonate with me that dementia is a silent epidemic with little warning, and the main driver for the increase is demographic change. Although the strongest known risk factor for dementia is increasing age, with most cases affecting those of 65 years and above, it is definitely not part of aging. So, what is aging and what is dementia? According to the CDC, dementia is not a specific disease, but a general term for the impaired ability to think, remember, or make decisions that interferes with their daily activities. They found it harder to communicate, express, and interact with the people surrounding them. There is no known theory that is developed to specifically explain the process of dementia. However, we can adopt the Piaget's theory of cognitive development for good understanding. This is a comprehensive theory about the nature and development of human intelligence since birth. Many diseases lead to dementia. Although, in the earlier slide, I mentioned that dementia cannot be treated because they are caused by Alzheimer's, multi-infarct, and its complex dementia. But if we take a further look at the list here, we will realize that dementia can be treatable if they are induced through reversible medical conditions. Besides pharmacological treatments, there are also many non-pharmacological interventions developed over the years, as shown here, to slow down the disease process. Over here, we had the reminiscent therapy, music therapy, massage therapy, environmental design features, exercise program, and art therapy. However, with moving times, the profile of our aging population evolves and requires different stimulants to create an experience on their behavioral and psychological symptoms. And in this review that we conducted, it demonstrated that online memory training intervention improves memory, cognition, and psychological status of people with dementia as well. Regardless of the strategies and interventions, it is important to assess their receptive level throughout their activities and respect their wishes to not participate in the program. Whatever the activities that we provided them, respect is important. To ensure that the activity is beneficial, a good assessment is to understand their pastimes, hobbies, and personality characteristics. I've now come to the end of my sharing. Thank you for your time. To understand more about healthy aging and well-being in Singapore, I welcome you to listen to my podcast channel, accessible via this QR code, where industrial partners, including social workers, geriatricians, nurses, and service providers in the community, coming together to share on their knowledge. I will now pass the time to our three speakers who will now share on their research projects. The overview of the projects focused on their work done on detecting, assessing, and improving the cognitive aspect of older adults. We will take your questions at the end of the session. Our first speaker, Dr. Catherine Dong, an assistant professor in National University of Singapore, Yong School of Medicine, NUS Nursing, will now share her research project on cognitive screening in the community, nursing practice, and implications. Dr. Catherine has cross-disciplinary knowledge in nursing and clinical neuropsychology. Her clinical expertise is in nursing and clinical neuropsychology, diagnostic assessment, and brain training intervention. Her talk will focus on the commonly used cognitive screening tools and its implications for community nursing practice. Catherine, please.
Thank you, Rosalind. Good afternoon to everyone. Welcome to this trend seminar. My talk today is on cognitive screening in the community and nursing practice and implications. So I hope at the end of this talk, you will be able to understand the cognitive screening concepts, including cognitive function and commonly used screening tests, as well as maybe could have some understanding of the cognitive screening approach. For example, what are the tools and whether it's a performance-based or informant report, or maybe even some simple risk score that can help to detect patients with cognitive impairment. So why do we do cognitive screening? I mean, knowing that there is the rising aging population and dementia is really on the rise too. So we know that even for people without dementia, like even at the mild cognitive impairment stage, that means they have mild memory thinking problem, it can be a problem for patients' day-to-day functioning because it's a barrier for their self-care as well. For example, when your patient has memory loss, he or she may have some difficulty in traveling independently or even locate the clinic, during their follow-up visits. Or they may have difficulty following medication regime or the complex instructions and increasing the risk for readmission. There's also that difficulty for them to recall the information when they, meet the healthcare professionals, and this may result in some miscommunication. So that's why it's important to do, cognitive screening. And then there are objective cognitive screening tests. And so for who? Is for those older patients at risk of dementia, and some of them actually have a subjective complaint of progressive or forgetfulness, and some actually, family members actually report this, elderly or this patient have some sort of decline in their memory thinking, in their functioning. So for that, this test should be done. So just give you an overview of cognitive function. Okay, so you know that cognitive function, in this chart, you can see, a lot of times we think about just memory, right? How we remember things, but it's more than that. It also includes attention, how we focus, language, our ability to understand others, express ourselves, and our visual, spatial, constructional ability is our ability to understand the space and depth and drawing in that sense. And then, of course, we have very important, skill, which is executive function ability, where is our ability to plan, organize, and problem solve. This is a higher level cognitive ability. And where are they located in our brain? Okay, it's everywhere in the brain, okay? It could, for executive function, the ability to plan, organize, and problem solve, and our concentration, the ability to hold information in mind is actually largely in the frontal parts, quite a large part of brain. And then for other aspects, for example, memory, or, like learning, it will be actually at the hippocampus, it's actually lateral part, yeah, and medial temporal lobe. And then the back is our ability to see, our vision, yeah, so that's where our visual spatial ability is at. So cognitive screening tests, how do we assess what kind of test might be useful, okay, and easy for us to adopt? We try to look for the ones that's usually brief. We're talking about less than 30 minutes in the test administration. You can have objective performance tests like the commonly used mini mental state examination or Montreal cognitive assessment, which take about 15 minutes. They're about 10 to 15 minutes. Or you can have an informant-based report on functioning change. We call it 88. And there is also a risk score we developed, based on demographic factors and risk factors. And this can be used to screen for normal functioning compared to those impaired cognitive functioning. And it's actually to form a preliminary impression on their cognitive status. However, it cannot be used as a standalone diagnostic assessment because it's merely for cognitive screening. It helps to determine the comprehensive assessment to follow up in a specialist memory clinic. So is there an ideal cognitive screening tool that is quick to administer, acceptable to patient, and easy to score, free of cultural and language education bias, and with good reliability and validity? That means they're consistent, they're valid. Is there one such tool? So hold that question in mind. At the end of my talk, we might be able to have an answer. All right? Okay. So when we do cognitive screening test, okay, or any cognitive assessment, it's important to consider some factors so that you can get best possible performance from the patient, and it's fair to the patient as well. So consider when you administer test when the patient is first alert and focused. You do not want a patient that's confused or feeling drowsy, then you're not getting the best test performance. And ensure comfort. For example, if someone is in great pain, obviously they cannot focus. And then your test may not be valid because the patient is distracted by the pain and physical discomfort. And at times, it's important to make sure their vision, the hearing is actually, there is no issue, because if there is an issue, if, for example, they cannot see, the words are too small, the drawing too small, it's important to provide magnifying glasses, or we encourage patient wear hearing aid. So do the test in a conducive and quiet environment. It's important to basically prevent distraction, and also prepare well before the test administration so that there is no interruptions. Yeah, and in the process, surely there will be some sort of fatigue or patient feeling anxious. So it's important to actually reassure patient and then motivate them to stay focused and to complete the test. So is a way that for us to move on to know whether their cognitive functioning is okay or not. So I'm going to give you a few, commonly used cognitive screening tests. First one is a mini mental state examination, MSE. It's just to let you have some idea what it looks like and, how to use it. So MSE is originally designed to differentiate the mental status in psychiatric patients, okay, inpatients. It's now as a screening tool and to track the progression of cognitive impairment. And it takes about average 10 minutes thereabout for administration with a score 0 to 30, and 30 as a maximum score. The higher score means better performance. There is age education adjusted cutoffs. So these are some questions for you to, the items in MSE, where you can see there's orientation items, for example, date, month, year, location, and there's registration item for them to remember 3 words, and then, attention item where subtract 7 from 100 and recall 3 words, and language, like for them to actually name pencil, watch, and then there's practice for them to copy this design. Okay, so each 1 point for each correct answer, and then total score is 30. The other commonly used test, Montreal Cognitive Assessment, is also a rapid screening instrument for mild cognitive impairment. It assesses attention, concentration, executive function, memory, language, and visual constructional skills. It also, basically assesses thinking, calculation, orientation. Total possible score is also 30 points. Average administration time is 10 to 15 minutes, a little bit longer than mini mental state examination. So that's what it looked like. This is our Singapore MOCA test form, where we adapted for the local population and make sure there is that comparison between English, Mandarin, and also Malay version. So it includes this, visual spatial ability. For example, first, in the first 3 tests is basically on the visual spatial executive function, which you can see a little bit harder than mini mental state examination. And in terms of the memory, there are 5 words to remember, okay, which is a little bit different as well. And abstraction is asking for similarities between items and things like that, a bit different, from MSE. So it's, there's 2 tests a bit different, where MOCA has tapped into other domains of cognitive functioning, where MSE is more of orientation based, So I'm just going to show you a quick video for you to see how the test is administered. I use MOCA as a, example, so you can have some idea. Okay.
Hello, sir.
Sir, how are you?
Good. How are you doing?
Okay.
Good. Well, I'm glad to have you back in the clinic. When you were here, a few weeks ago, we were looking into some eye problems that you were having. But during that visit, we were also talking about your memory. And you had expressed some concern about your memory. And we did a short test in the office that suggested we might want to look into your memory a little bit more. So we're here today to do that. So what I'm going to do is we're going to start with some questions. And these questions require a little bit of concentration. Some of them are easy, some of them are more difficult. Okay? So I just want you to do your best. And if you can't hear me or you need anything clarified, just ask me any question you want to.
Good enough.
Okay. I'm going to give you a pencil first. Okay? And I want you to look up in this corner.
All right.
What I want you to do is draw a line from a number to a letter in ascending order. Start at number 1, draw a line from 1 to A to 2, and so on, and end here.
So we look at A, 1 to A, 2 to B.
Yes, exactly. Can you do that now?
Yep. 1 to A to 2, 2 to B, B to 3, 3 to C, C to 4. Wow. Four to D, D to 5. How's that? Oh, and the end.
Good. I told you some of these were a little bit tougher than others.
Okay.
You see this design here?
Yep.
I want you to draw that design in the space provided below.
All right.
Okay. In this space, I want you to draw a clock for me. Make a big circle and put all the numbers where they go. And now, Sam, I want you to set the time for 10 past 11.
This is 10 here.
Okay. Okay, I'll take the pencil back for a minute. Now I want you to tell me the name of this animal.
Lion,
What's the name of this one?
rhinoceros,
How about this one?
camelorino, camel.
Okay, good.
I just thought I'd make them an Italian.
Are you ready for the next thing?
Yeah.
Okay. The next thing is that I'm going to read you a list of words, and I want you to concentrate because I want you to remember them now and later on. Okay?
I'm bad at that.
That's okay. This is just do the best you can. Okay? So listen carefully to the words, and then you say them back to me in any order.
Okay.
Okay? Here are the words: face, velvet, church, daisy, red. Go ahead.
Face, velvet, daisy, church, red.
Perfect.
Okay, great. So this video actually shows us how Montreal cognitive assessment is done. And you can see that the elderly gentleman is feeling a bit unsure, so that assurance is provided by the doctor. So that's what we need to do when we do cognitive testing, is actually assuring them, encouraging them, motivating them to continue. So it's like cognitive tests to a lot of patients, they may feel it's like, exam, like back to school doing exam. They feel, they worry that whether they'll pass or fail. So we have to assure them there's no such thing as pass and fail. It's more of like, it's like checking your blood pressure, right? It's just a screen. It's to know whether how you're doing with their memory thinking ability. So I think a lot of time it's important to actually assure them. So this is just a short clip for you to say how the test is done. So, it's quite important to follow the standardized administration for the test rather than making up our own words. And it's important also try not to help the patient, because some people feel, the patient feeling anxious, I need to help him. It's important to be neutral, to be objective, and not help the patient, because you want to also, if there's deficit, you want to detect the deficit. All right, moving on. So we have discussed that, and then now moving on to something that's based on informant. That means patients and family, caregiver, for dementia screening. So informant-based interview is basically could be done with a spouse, patient spouse, or the adult children, or their significant other, like friends. Okay, it can take about, less than 3 minutes. This informant ADA take less than 3 minutes, and there's eight item screen for intra-individual change, which is asking about change, like whether there's any change in memory, judgment, etc., compared to previous functioning. And it's quite sensitive to early signs of dementia. So we have done previous study in the primary care setting, polyclinics, and we found that for patients aged 60 years and above, with informant 83 and above, this test actually has excellent dementia case finding capability. It's actually superior to the mini mental state examination and equivalent to the MOCA. Yeah, so if you're interested in that paper, we actually have it as a reference. So our recent development is the risk score, because some people say, you have all these tests take time, and then could we actually just have some, tests, some things we can use that based on the demographic factors and some risk factors, because these are in the system, right? So we actually developed a risk score predicting cognitive impairment, which we call it total risk score, TRS. So what are the risk factors we're looking at? If patient is age more than 70 years old, you give a score of 3. If the patient have diabetes, you give a score of 2. If the patient have stroke, then 1. And if it's female, then 1. And if patient has cognitive complaint, or complaint of memory change, okay, in daily problems of thinking and memory, by either patient's family member or themselves, you give a 1. And the total risk score 3 and above predict this person actually at risk of cognitive impairment. So we will suggest to to follow up with a Montreal cognitive assessment to help to say whether it's something serious to requiring specialist clinic referral. Yeah. Okay, so what are the benefits, and drawbacks of doing cognitive screening? The benefit is obviously we know it's early detection. Then we can have early intervention. It's a first step, also educating our community dwelling older adults on healthy aging and brain health. Because memory thinking is brain health, right? And then the drawback is actually there is also that possibility for potential psychological, social, ethical impact in the screen positive persons, older adults, but they are actually not meeting the criteria for dementia after formal evaluation. They'll be worried, am I having dementia? What am I going to do? All that anxiety. So that also the low mood, anxiety, and there's such kind of thing like called labeling effect. Some people start labeling themselves, the family label themselves. Maybe they having dementia, but actually they don't have it. And there's also the time and cost of screening. So it's very important to manage the drawback so we can do this screening practice. So in summary, this talk basically gives us some understanding about cognitive screening concepts, and then what is the cognitive function in general, what are the commonly used tests. Also, we discuss some cognitive screening approach, for example, like performance-based tests like mini-mental state examination, MOCA, and informant report like 88, and risk score like total risk score, which is just demographic factors, risk factor you can draw from patient's history, medical record. The general rule for cognitive screening is use validated cognitive screening tests with the awareness of benefits and drawbacks, so you can manage both. Okay, so these are my references. You can read a bit more if you are interested in the approach. So that's my presentation.
Thank you, Catherine. Cognitive frailty is common among older adults. It is an independent predictor of various adverse outcomes, including dementia, decreased activity, disability, of various adverse outcomes, hospitalization, and all-cause mortality. Therefore, identification and management of cognitive frailty should be incorporated in routine clinical practice. Today, we have our second speaker, Dr. Ruby Liu, from the Chinese University of Hong Kong, Faculty of Medicine, CUHK Jockey Club Institute of Aging. She will be sharing her research project on cognitive frailty, a predictor of adverse outcomes among older adults. Ruby, please.
Thank you, Rosaline, and welcome to this section. I'm Ruby. I'm going to talk about cognitive frailty and its association with adverse outcomes. So this is my PowerPoint. Let's begin with some background information. So what is frailty? Frailty was developed over 2 decades ago as a concept describing the aging process as a biological state. There are several definitions of frailty, and the definition of the WHO is being most representative. It states, frailty is a progressive age-related decline in physiological systems that results in decreased reserve of intrinsic capacity, which confers extreme vulnerability to stresses and increase the risk of a range of adverse health outcomes. The figure on the left shows this state of vulnerability. The green line represents a fit elderly individual who, after a minor stressor event such as an infection, has a small deterioration in function and then returns to homeostasis. And the red line represents a frail elderly individual who, after a similar stressor event, undergoes a larger deterioration, which may manifest as functional dependency and who does not return to baseline homeostasis. And the horizontal dashed line represents the cutoff between dependent and independent. Regarding the operationalization of frailty, 2 groups of researchers mainly dominate the discussion. One group defines frailty according to a physical phenotype, namely the phenotype model, and has tracked the most attention of researchers. In this phenotype, frailty is defined as a purely physical condition and therefore consists of solely physical components, including weight loss, exhaustion, weakness, slowness, and low physical activity. And the presence of 3 or more of these 5 components has been considered to indicate frailty. The other group defines frailty according to a broader definition, including social and psychological aspects, namely the cumulative deficit model, which forms the basis of the Canadian Study of Health and Aging Frailty Index. This index was a simple calculation based on a range of variables, including symptoms, signs, disabilities, disease, and various laboratory measurements. In addition to these two operationalization of frailty, many variations on this definition can be found in the literature. Also, with reference to the broad frailty definition, some researchers had developed their own criteria for frailty. So let's see the prevalence of frailty. Many researchers assess the prevalence of frailty, and the range of frailty rates found in the literature was wide, which was due to the diversity in frailty definition. In studies that use physical frailty definition, the weighted average prevalence was 9.9% for frailty and 44.2% for pre-frailty. And in studies that apply the broad frailty definition, the weighted average prevalence of frailty was 13.6% and for pre-frailty 33.5%. And the results showed that women had higher rates of frailty than men. In women, the weighted average prevalence of frailty was around 9.6%. In men, it was only 5.2%. This finding is not unexpected, given that women have lower average amounts of lean body mass and muscle strength. And the relationship between frailty and sarcopenia has been confirmed in previous research. Another explanation is that the longer life expectancy of women, as a result of which the women in the age group were older than men. So because frailty increases with age, this could contribute to the difference between the two genders. In addition, the results show that the prevalence of frailty increases with age. The prevalence for frailty was around 15.7% for those aged 80 to 84 and 26% for those aged 85 plus. From a clinical perspective, frailty is important because it constitutes a condition of greater risk of adverse health outcomes. It is known to be associated with delayed recovery from illness, increased risk of falls, poor mobility, less independence, hospitalization, disability, and death. And the explanation for this increased health risk is related to a reduction of the reserve capacity of various physiological systems. And frailty appears when the reserve capacity has decreased to a critically low point. So when even small infection can lead to a series of complications. Although frailty is associated with various adverse outcomes, it is not an inevitable part of aging. It is therefore important to identify when a person is frail or is at risk of becoming frail through use of evidence-based screening tools. Timely identification of frailty can enable health and social care professionals to prevent a poor outcome for an intervention and support the long-term management of people's health needs. Numerous tools are available to identify frailty, and this table shows the features of some selected screening and assessment tools. There are summaries of each tool, which includes the level of expertise required to administer the test, together with a rating of 1 to 5 for the time taken to administer the tool. For example, the Clinical Frailty Scale, CFS, is a measure of frailty based on clinical judgment. It has been designed to grade the severity of frailty following a comprehensive geriatric assessment. The Frail Scale is a questionnaire comprising 5 yes/no questions, which enables the rapid identification of individuals with frailty to target with focused interventions. The PRISMA 7 questions cover 7 items, including the age, gender, whether the person limits his or her daily activities, etc., and 3 or more yes answers indicates that the person is frail. The fourth one, the Gerontopos scale consists of a series of questions for identifying signs and or symptoms indicative of frailty. The fifth one, the timed up and go test, is a test of functional mobility. It measures the time taken to stand up from a standard chair, walk 3 meters, turn, walk back to the chair, and sit down. And the last one, the electronic frailty index, EFI, uses existing electronic health record data to detect and assess the severity of frailty. It uses a cumulative deficit model of frailty, in which frailty is defined through the cumulative of deficits, which can be clinical signs, symptoms, disease, and disability. And here, the EFI comprises 36 deficits, which have been developed using GP recodes. Now let's see what is cognitive frailty. As I have just mentioned, at present, the concept of frailty has focused principally on the physical domain. However, some researchers have started considering cognition in the definition of frailty. In view of the increased interest in frailty and its relationship to the aging brain and the continued goal of developing strategy to improve disability in older people, a workshop of cognitive frailty was conducted by an international consensus group, IANA and IAGG, in 2013 in France. And the group discussed and proposed a first definition of cognitive frailty as a heterogeneous clinical manifestation characterized by the simultaneous presence of both physical frailty and cognitive impairment. In particular, the key factors defining such a condition, including presence of physical frailty and cognitive impairment, defined by the clinical dementia rating of 0.5 and the exclusion of concurrent of dementia or other dementias. The two defining criteria imply that cognitive frailty is characterized by reduced cognitive reserve, but is different from the physiological brain aging. At the same time, it is noteworthy that under different circumstances, cognitive frailty may also represent a precursor of the neurodegenerative processes. A potential for reversibility may also characterize cognitive frailty. According to the IANA or IAGG group, the primary criterion of cognitive frailty is the presence of physical frailty and MCI, mild cognitive impairment without dementia. However, different states of cognitive vulnerability and frailty may be also relevant to identify older persons with cognitive frailty. Furthermore, it is likely that MCI may represent a later stage of cognitive frailty, cognitive impairment at which multiple domains of cognition have already occurred. So early detection of abnormalities in specific domains of cognitive function together with identification of the pre-frail state may allow opportunities for reversibility through interventional strategies. In an attempt to define the framework for the definition and potential mechanism of cognitive frailty, a group of researchers proposed two subtypes for these clinical constructs, namely potentially reversible cognitive frailty and reversible cognitive frailty. The physical factors should be physical pre-frailty or frailty for both the subtypes, and the cognitive impairment of potentially reversible cognitive frailty should be MCI as proposed by the IANA IAGG consensus group, whereas the cognitive impairment of reversible cognitive frailty subtypes should be pre-MCI as subjective cognitive decline. So let's look at the prevalence of cognitive frailty. A recent review paper reported that the prevalence of cognitive frailty was around 6%. You can see that among the studies include the Fried criteria was the most commonly used to define frailty in community during older adults. A total of 29 studies report the prevalence of defined frailty, and some studies use the MMSE to evaluate cognition, and some studies use MOCA. And in this case, the prevalence of cognitive frailty is quite different. So using combined data from the defined frailty, you can see the prevalence of CF was 6%. When the report rates were restricted to the study that used potentially reversible cognitive frailty, the estimate preference rate was 16%. According to another cohort study, which included around 700 Chinese older adults with intact cognition, the preference of reversible cognitive frailty was higher, of 27.8%. Like physical frailty, cognitive frailty captures an element of vulnerability that is often present in older people who are not yet disabled, but may make them vulnerable to developing various adverse outcomes, including low physical strength, physical limitation, poor quality of life, poor cognitive function, dementia, hospitalization, disability, and all-cause mortality. This table shows the association between cognitive frailty and adverse outcome report in a study conducted in USA. The study population was over 7,000 older adults, age 75 plus. We can see that participants with cognitive frailty were associated with a higher risk of incident ADL dependence and mortality over 8-year follow-up when compared to those without frailty or no cognitive impairment. In another study conducted in France, with over 4,800 community-during older people included in the study, the table shows that participants who were frail and with cognitive impairment had a higher risk of incident dementia at the 4-year follow-up when compared to those who were non-frail and without cognitive impairment. Our team also examined the association of potentially reversible cognitive frailty with various adverse outcomes. And in this study, we have recruited around 3,500 community-during older people. And we found that compared to participants who were robust and cognitively intact at baseline, those who were pre-frail and with cognitive impairment had lower grip strength, lower gait speed, poorer lower limb strength, and poorer delayed recall at year 4. And we also found that they were also associated with increased risk of poor quality of life, incident physical limitation at year 4, and cumulative hospital stay at year 7, and mortality over an average of 12 years after adjustment for various covariants. And this study examined the association between reversible cognitive frailty and adverse outcome. This study was conducted in Italy with around 2,000 community-during older people included in the study. And this table shows that the participants with reversible cognitive frailty showed an increased risk of overall dementia and all-cause mortality over a 3.5-year follow-up. And similar results were also shown after a 7-year follow-up with an increased risk of both dementia and all-cause mortality. Our team had also examined the association between reversible cognitive frailty and adverse outcomes. This study was conducted in China with 700 older people included. And participants with reversible cognitive frailty had high risk of the incidence of ADL, IADL disability, poor physical quality of life, poor mental quality of life, and depression over 1-year follow-up. And here shows the results of a meta-analysis, including 12 studies. And the results show that cognitive frailty in older people had a higher risk of all-cause mortality and dementia. Since cognitive frailty is very common and that it was associated with adverse health outcomes, identification and management of cognitive frailty should be incorporated in routine clinical practice. In view of this, we have collaborated with various elderly centers in Hong Kong to implement a community-based program since 2020, consisting of 3 focus areas. First, to identify older people in need of care in the community, we formed partnerships with community elderly centers to undertake needs assessment for older people. In collaborating with over 100 centers, we conduct a survey, longitudinal survey, to monitor the needs of older people. They were assessed annually. And we designed a needs assessment form covering a list of common geriatric syndromes, including frailty, cognitive impairment, sarcopenia, medications, incontinence, self-rated health, IEDL difficulty, etc. And each participant was given a tablet computer to complete the survey by themselves. Alternatively, program workers of the elderly center could guide the participants to finish the survey. Second, to mobilize community resources to manage cognitive frailty, the project supports elderly center to develop and organize health promotion programs that target cognitive frailty and functional ability. The programs focus on 5 areas, including exercise, healthy eating, cognitive training, social connectedness, and mental health. And routine data on program participation were collected using a custom digital event management system. And preliminary data showed that multimodal exercise and cognitive training with video games offer great opportunities to prevent frailty and cognitive decline and thereby care dependency. The third area is relating to a capacity building. We developed a capacity building program for social care providers and program workers to strengthen their knowledge and skill to perform needs assessment and deliver health promotion programs that target cognitive frailty. The program covered different topics, including frailty and cognitive assessment, promotion of multimodal exercise, promotion of healthy diet, and geriatric care. Interim evaluation results revealed that the program was well received. 80% of participants mastered the skills in performing the frailty and cognitive assessment and discussing the results with older people. And over 70% of participants were confident in providing or implementing relevant interventions for managing cognitive frailty. For example, providing multimodal exercise, cognitive training with video games, and nutrition information about healthy diet. So to summarize, cognitive frailty is common among older people, and the estimated prevalence was 6% for cognitive frailty, 16% for potentially reversible cognitive frailty, and 28% for reversible cognitive frailty. Cognitive frailty, including all subtypes, were associated with various outcomes, including low physical strength, physical limitation, poor quality of life, poor cognitive function, dementia, hospitalization, and all-cause mortality. So identification and management of cognitive frailty should be incorporated in routine clinical practice. So that's the end for my presentation. Thank you very much.
Thank you, Ruby. Our third and final speaker, Dr. Vivian Wu, also from National University of Singapore, Yong Loo Lin School of Medicine, NUS Nursing, will be sharing on the community dance program, promoting cognitive, physical, psychosocial health of the older adults. She'll be sharing about a dance program to improve cognition, muscular strength, balance, and psychosocial well-being of the older adults. Vivian, please.
Hi, thank you, Rosalind. Thank you all for joining our session today, and I'm very glad to see that Catherine and Ruby actually shared about the cognitive decline and frailty, which are the really the physiological changes faced by our older population, right? So as nurses, of course, we conduct screening and assessment to detect early changes in cognition and frailty, but it is also important for us to develop programs or interventions to support the older adults and help them to face those issues, right? So I'll be share a programs on dance that we have developed and implemented in the senior activity centers. Before that, we actually have conducted a meta-analysis to evaluate the effect of dance on the cognition, neuroplasticity, physical changes of older adults with MCI, and the evidence has clearly shows that dance as a aerobic exercise, it actually promotes blood circulation and it helps to activate the brain activity. So in a way, it will enhance cognition. And of course, while practicing dance, the older adults will need to remember the dance steps, the coordination, and it helps with the visual spatial domain of the cognition as well. Right. So of course, dance is always, most of the time is a group activity. So it promotes communication, language domain. It also encourages the social networking connection as well. There's physical movement, which the older adults need to be engaged in the dance process. So in a way, it actually promote physical function. And while they are dancing, it always comes with music. That's, higher level of enjoyment, better mood, and they would be happy to share their feelings. And of course, dance is a non-pharmacological intervention, so it is less costly. So feel free to take a look at our review paper on that. So what we did is that we actually recruited older adults at 55 years old and above, right? Those who are able to speak either English or Mandarin, willing to give consent to participate into the program and are able to commit for the 8-week dance program. We did some pre-assessment just to ensure that, the older adults are, to ensure their safety, both in terms of their cognitive and physical capability. So we actually conducted a pre-assessment screening using SPPB to evaluate their physical capability and using MOCA to evaluate their cognitive capability as well. So we excluded those who have severe cognitive impairment like dementia, severe psychiatric disorder like schizophrenia and so on, or severe depression, or those who may have severe vision and hearing impairment, because those could really kind of interfere their participation in dance. So overall, it's a 8-weekly session dance program. We actually it is really a community participatory approach. So we actually work closely together with Senior Activity Center, and we also invited student dancers from NUS Center for Arts. So we actually sit down for meetings to craft up the program, which try to understand the needs of our local population of the older adults. What do they need? What do they want? And also, of course, try to customize a dance program which cater to the needs of our local population. So the 8 sessions. First session, of course, we started with introduction of the dance program and some basic warm-up. And then session 2 to 4, we started with step-by-step learning, and then more about small group practice with the guidance of the student dance instructors from NUS. And session 5 to 6, and then we focus more on the practice of dance formation, rehearsal, and the last 2 sessions then focus more on the dance formation and re-practice as well. So you could see that, the initial plan is, of course, to conduct session over face-to-face, right? And this study was actually conducted in 2021. So in the process of the intervention, and there's a heightened alert due to COVID. So, then the older adults are advised to stay at home, and the visitors are not allowed to enter into the center. So hence, we have to do a urgent or really immediate switch from face-to-face intervention to switch to a virtual session. So from session 2 to 6, we actually delivered using Zoom, right, through virtual format. And the last 2 sessions, so when the safety measures was more relaxed, we managed to switch back to face-to-face session. So these are some of the pictures taken from the dance session. So initially it was started with very gentle movement, sitting on a chair, kind of gentle movement. And when the older adults are more confident, then we move on towards standing and more higher level of movement. So the dance instructors actually, design the dance in a way that, they actually integrated with a theme of nature, talk about forests, talk about, going to the beach, to integrated with some imaginary guidance, and also some themes is about traveling. So every 2 sessions, we actually focus on a special theme. Yeah, so just a quick video on the dance program. Okay, so these are the pre and post assessment we have done. So basically, with the background of the systematic review, we actually evaluated the cognitive domains, using a brief cognitive test, MOCA, and SDMT, which evaluated the processing speed as well, and we conducted physical measurements, using SPPB and other measurement. Physical tests basically to look at their, walking speed, gait, balancing, and we're actually using a special device, MOXIE device, to evaluate their limb power as well. So we have also collected saliva sample to evaluate the biological age, of the older adults. So those are the assessment we have done pre and post, and we conducted the sessions, in 2021, and the eventual post assessment was completed in April 2022. So in total, there were 54 older adults participated in the study, 27 in intervention group, and another 27 in the control group. In addition to the quantitative evaluation, we also did a follow-up process evaluation. So this is a more about a qualitative exploratory kind of approach to explore the experiences of the older adults and also the student dance instructors on their experiences of the dance program, more from the perspective of to evaluate the strengths and the limitations of the community dance program. So we conducted 4 focus group for among 20 older adults, and 2 focus group with 10 student instructors participated. So after that, we used thematic analysis to analyze. So you can see that the age range is all 70 and above. So many they are the middle old to old, right? And most of the participants are actually female. Then we have a good distribution over ethnicity. And then for this group, this generation of older adults, there are many fall under the lower education profile. So you could see that most of them are actually without any formal education or primary school level. Okay, religions-wise, yes, sir, quite a wide variation. And most of them are living into 1 to 2 room of HDB apartment. For our international participants here, HDB is actually a government subsidized apartment for the older adults. Okay, and interestingly, I think it's important for us perhaps to take note that more than half of the participants are actually with more than one comorbidities in terms of their chronic conditions. Okay, yeah. So this is the preliminary results, or what you can see. We can see from here is that, you know, in terms of the SPPP, their physical domains, right? If overall we can see there's an increase in terms of the direction. Of course, the p-value won't be significant because of the small sample size, right? Yeah. So you know, really we want to look more into the direction, and there's improvement in terms of the hand grip for the intervention group as well. Yeah, under the cognitive variables, right, there's a you know, upward change, increase for the MOCA as well. Yeah, in terms of happiness, they feel happier. Yeah, there's a slight upward trend, and there is a significant change in terms of quality of life. Yeah, so good to know. Yeah, so for social support and you know, their satisfaction as well. Yeah, we also evaluated the intergenerational communication between the older adults and the student instructors. So interestingly, that's you know, significant change in terms of the GPIC non-accommodation. Yeah. All right, so in terms of the focus group discussion findings, so we did the thematic analysis, and the brief report has been published in a book chapter. Yeah, so in general, there are three major themes that emerge out from the discussion. Yeah, so what we can see is that, you know, the participants enjoyed the, you know, the dance which are integrated with the theme of nature and word travel based you know, dance techniques. Yeah, like, you know, some of them, you know, this is a quote from participants. They mentioned that, you know, because of COVID, I couldn't travel for 3 years. So I imagine that, you know, we are all traveling from Japan to Thailand, and then we imagine the kind of costume and culture that in each country. Yeah. And some older adults feel that, you know, it's a reminiscence for them to recall those good old days in their younger age. Yeah, so they feel that, you know, I can still remember when I was younger, my legs can do everything in dance. So I'm very happy. Yeah, it also helped to enhance their memory. Yeah, because they have to, you know, recall and practice a series of dance steps, right? And some of them actually are very, very committed. They even go home and continue to practice the dance steps. Yeah, so in a way, they feel that, you know, they can memorize the dance step better. All right. Okay, so some of them feel that, you know, it actually helped them with their physical health through the dance program. They feel that, you know, their weight has a reduction, and then their body feel lighter and more flexible. They can move more freely. Yeah. Some of them share that, you know, they had back pain in the past. They cannot bend previously, but you know, after engage in the dance, you know, they lose some weight. They feel more flexible. They could bend their knees now. And they also enjoyed the social interactions within the older adults and with the student instructors as well. You know, one older lady shared that, you know, it is very good that, you know, the students come to us, they interact with us. We definitely have generation gap, but it helps us to know each other better when we talk. Dance also help them to enhance their mood. Yeah. Help them to feel relaxed, refreshing, and some share that, you know, I really feel happy when dancing, and I think I want more dance exercise in future. Yeah, so it's very you know, exciting for us that, you know, in the discussion they even requested for more dance program and longer duration. They even asked us, when are you coming back again? Yeah. Okay, yeah, so for the last team, And the elderly also highlighted some concerns regarding the session which were conducted over Zoom. Yeah, so they shared that they prefer face-to-face session because they could ask questions directly, and the instructors could correct them in terms of their postures, movement, then. Yeah, whereas when the dance was conducted over Zoom, sometimes, the system could be a bit laggy, yeah, and it's more chaotic. So they feel that they could injure themselves if they don't really understand the steps and cannot follow up with the instructors. Yeah, so the instructors also highlighted that, online communication is not the ideal platform for delivering dance. Yeah, and they feel that sometimes when they give instructions over Zoom, for example, when they raise the left hand, and because it is an opposite image, so then the participants will raise the right hand. Yeah, so in terms of communication, it's a bit more challenging for the student instructors. Yeah, they also highlighted the issue of language barrier because our older generation, some of them speak dialects only. So student, being the young generation, they may not be very fluent with our local dialects. So they also feel that, there's a student instructors in general, they feel that there's a need for them to pick up more dialects or, language like Malay, so they can communicate better with the older adults. Yeah, so this is really a pilot study that we have conducted, but actually give us the confidence that, dance program could promote not just physical health, but also cognitive and psychosocial health for the older population. Yeah, and in a way, it actually promote the intergenerational communication between the older adults and the young adults as well. So we would like to acknowledge the Community Mental Health Fund and Lion Befrienders Senior Activity Center. Really appreciate all the staff who supported the entire program, and NUS Center for Arts, yeah, who, which really very engaging, and we coordinated and collaborated on the program. Thank you so much.
Thank you, Vivian, for your time. And I can see that you enjoyed this entire process, and I believe it serves as very well and very good motivation for all of us to emulate. I will now open the floor to the audience to continue the question and answer session for the speakers. And while questions are coming in, I would now like to also address certain questions as much as we would like to, because we have multiple questions coming in. Yeah, so the first questions that perhaps I would like to direct will be our Dr. Catherine. Yeah, Dr. Catherine, are you there?
Yes.
Hi, Catherine. Yeah, we have participants that's asking, as the test, I believe, is the MOCA test or the MMSE test, being administered by a test giver. What are the measures to ensure that there are no bias or influences by the test giver that may affect the patient's results?
Yeah, thank you very much for the question. It's true, this is quite a common situation and concern. So different test administrators surely will have their preference, but to respect the integrity of the test, also fairness for the patient taking the test, is very important for us to actually follow the standardized test administration instructions. Not to use our own words or whatever, try to follow through. So there are specific ways to actually instruct the patient to do the test. For example, the MOCA, they did say, try to remember the 5 words, I'll test you later. So, if you don't tell the patient that I will test you later, they actually may not make an effort and you are unable to assess their memory. Okay, so then there's also, in terms of the bias and influence from tests, administrator is sometimes, I think, the common influence or bias is actually from the helping profession, the healthcare professional. I can say that a lot of times people try to help the patient, from your nonverbal language, you like nodding your head, wherever you're not, when they're giving the right answer, you're nodding your head. When they give you the wrong answer, you show in your face, even though you don't say that something gone wrong. It's actually quite, that will be an influence, quite a significant influence, because patients see you, and then they will start doubting themselves. They will be like, losing interest, and they take your nonverbal cues as a way and then getting whether they're doing right or wrong, So it's important to acknowledge the effort. Even they are wrong, we can just say that good effort, keep going, things like that, rather than keep, like showing nonverbal language that they are wrong or they're correct. You know what I mean?
Thank you, Catherine. And following on with this thought in line, another question is trying to ask, right? According to the literature, MoCA has more specificity and sensitivity than MMSE. So the question is, can they just use MoCA to screen patients with MCI, or should they still follow the current MCI diagnosis?
Okay, so yes, MoCA is actually designed to screen MCI patients. Okay, well, MCI is more for the psychiatric inpatient, kind of a status check orientation in that sense. So yeah, it's designed to be more pick up MCI more easily. But I would think like the test itself is most important. You found the one is culturally, linguistically relevant, appropriate to the population. More importantly, there is a relevant cutoff and validation study done. When I say the validation study, you're looking at not just published cutoff, like, for example, MoCA original study is less than 26. You can't just use less than 26. You should use it for specific population. For example, the MoCA test for stroke, elderly stroke patient, it will be different from MoCA cutoff for the MCI, just older adults without any stroke. So because there's a prevalence difference, so therefore the cutoff will be different. So it's important to find the right cutoff for specific population, even though it's within the same population within the same country in that sense. And also different versions of MoCA. For example, the Chinese MoCA may be different from the English speaking population. So the MoCA cutoff would be different as well. So I think, yeah, you can use MoCA. You can use, more importantly is the test that is validated, linguistically, culturally specific to the population. Yeah.
Thank you, Catherine. Now we have a next question, and that will be addressing to Dr. Ruby, right? The question is, where can we get the CF, I believe, cognitive frailty test? And what are the intervention measures or programs that we can do, either individually or as a community? Ruby, please.
Thank you for your questions. And I think in Hong Kong, we can do the test in some elderly centers and also memory clinics. We can do some frailty screening. For example, some elderly centers use the frail scale for doing the screening test for frailty. And they also use MoCA or some other cognitive assessment to do the screening for cognitive impairment. So combining the results of frailty screening and also the cognitive screening, we can have some results for assessments for cognitive frailty. So if an elderly individual have at risk of cognitive frailty or becoming cognitive frailty, they will be advised to join some group programs. And for example, in the elderly center, we have already collaborate with some elderly center to implement some multi-domain programs, for example, including exercise, cognitive training, and also some nutrition education and some social activities. So combining all these multi-domain activities, I think this can decrease the risk of being cognitive frailty. Also, we will advise those who have at risk of cognitive frailty to have some adjustment for their diet if their diet is not healthy enough. So we can we provide them some guidelines so that they can eat more healthily. And also we can we advise them to do some regular exercise at home regularly. So just a healthy lifestyle to hope that improving their frailty and cognitive status.
Thank you, Ruby. Right. And the other questions that is being asked of is the types of interventions that would you recommend that would be effective to manage or prevent cognitive frailty?
I think the most effective intervention is multimodal intervention or multi-component intervention, including the core is physical exercise, including resistant strength training, aerobic, and also some flexibility exercise. And the other component is cognitive training. In a previous study, we found that cognitive training using video games can improve the elderly's some memory and cognitive functions if they had cognitive frailty. And also, I think the other important component is nutrition. We always give them some guidelines or individual consultations to ask the elderly individuals to have a more balanced diet and healthy diet. And if they had a risk of frailty or sarcopenia, we will advise them to improve their protein intake, etc.
Right. So you are suggesting that the recommended cognitive diet recommended will be more towards a protein diet?
Yes.
Right. Thank you, Ruby. Right. So the next question that I would like to invite Dr. Vivian, right, to share about what are the challenges that you have encountered in the process of program development for older adults?
Thank you, Rose. Yeah, I guess the challenges is really more about the needs assessment for the older adults. Yeah, because really, like Catherine mentioned just now, even across different country, right, the population is different, the culture is different, the needs are different. So I really encourage, the researchers to work closely with all the stakeholders, like our older adults, the community staff, right, the social support staff, to sit down and craft out, understand, really first step is to understand the needs of our older population, and then work towards, craft the program based on their needs. So in a way that, the program will be really customized according to the local population, and in terms of the feasibility, the acceptability will be much higher. And in fact, throughout the past 3 years when I was working with older adults, it's really encouraging to see that, in general, the older adults, they are very committed, very responsible people. So once they, they are committed to join the intervention, join the program, they are really, very conscientiously will come every session, even though the program is 8 sessions, 12 sessions. And, when they know that, they can't come for the session for the subsequent weeks due to their medical appointment, they will inform us much earlier, and they feel so sorry about it. So a lot of times we reassure them it is okay. We can even give you a private tuition for that. So in a way, I think it's very exciting to work with older adults, to appreciate them. Yeah, really. So building rapport is the first step, and so then it comes with a trust. So they are more willingly to work together with us.
That is indeed an experience. And in the interest of time, we can take in one last question. We are truly humbled by all the incoming questions that we're unable to answer. But please pardon us. We will now address the last question that is for Vivian, right? So Vivian, the question from you is that square dance actually is a very popular activity in China. Elderly women dance every night without the limitation, perhaps regardless of the weather. So if you want to examine the function of square dance and do some research on it, could you please give us some, advices and guides?
Mm-hmm.
Oh, sure. I think when we do the systematic review, it is really lightening for us to see that there are so many different kinds of dances that's available. Yeah, and it really, the type of dance that we choose really closely related to the culture. For example, in Spain, the Latin dance is more popular. Yeah, in Europe region, ballroom dance is more popular, whereas in China, square dance or line dancing could be more popular. So I would suggest that the types of dance in terms of the selection, the choices, really we have to understand the local culture and what the older adults. So in a way that we choose a type of dance that they prefer, so to get the easier buy-in. Yeah, and then like Ruby mentioned earlier, yeah. So the types of intervention actually focus on exercise, physical exercise, and cognitive training. So dance is it's really a combination of both physical and cognitive. So and at the same time, it actually brings enjoyment with the music, with the movement. So it helps with the mood, especially like a mood disorder as well. Yeah. So I would really suggest that the specific type of intervention really have to work closely with the community sectors, and then in terms of the evaluation, so it really depends on the outcomes. So if we are looking at the physical, cognitive, and psychosocial outcomes, it is good for us to select those instruments which are validated in our local context. So that will be relevant. Yeah. So I think Catherine and Ruby has shared a lot in terms of the types of instruments, in terms of the screening instruments and the tests that we can use in the intervention. Yeah. Happy to have further discussion with you. Yeah.
Yeah, indeed. Yeah, I thought that this question is very enlightening because we see collaborations, between different cultures. And feel free to connect with Dr. Vivian if you would like to have more insights with her experience. Right. Thank you, everyone, for your time and for joining us today. We hope this session has been insightful. And on behalf of NUS Nursing, we would like to invite you to visit our website to discover more exciting research projects and our education programs. NUS Nursing welcomes collaboration and interest parties joining our programs. And once again, thank you and have a good day.
All up in my head, fear's got a hold of me. Pretend I'm not scared of who you call.